Can everyone see and hear me correctly before I start the webinar? Beautiful. Well, hi everyone, and welcome to Reimagining Cannabis and Public Health, a people-first approach to policy, research, and equity. My name is Meredith McGee. I'm joining as a Parabola leader and a Yale public health student where I work at the intersection of policy, research, and community health. I will be your moderator today, and I am so glad that you are here with us. We're joined today by an incredible group of panelists who are bringing their expertise across policy, research, and implementation, each with a deep commitment to equity in public health and cannabis spaces. Tauhid Chappell is the first executive director of New Jersey's Cannabis Academy, the country's first government-run cannabis academy focused on building a diverse, inclusive industry. Jane Allen is a senior analyst at RTI International, where she works in the Center for Communication and Media Impact, focusing on cannabis and tobacco research and evaluation. Chelsea Higgs-Wise is the executive director of Marijuana Justice, where she works to advance legalization efforts that center on repairing the harms of the drug war, especially for Black and Brown communities. And Jim Seaberg is the assistant director of Drexel's Medical Cannabis Research Center, where they focus on advancing clinical, public health, and translational research related to cannabis. Together, they all reflect different pieces of the public health puzzle, and we'll be looking at how those pieces come together to build people-centric, equity-driven cannabis policy. So let's get started. Here's a quick look of where we're headed today. I'll start off by framing the conversation, what it means to think about cannabis policy as public health and why that lens matters. Then we'll hear from each of our panelists through short, focused talks that reflect different parts of the public health framework. We'll start at assessment with Jim and Jane, then shift into policy development with Chelsea, and then end at assurance with Tauhid. Finally, we'll end with a Q&A session where we'll dig deeper into some of the themes that came up and then also respond to some additional questions that we get from you. We're keeping the presentation short and engaging so you get a good, strong sense of what this looks like across the sectors and how public health can show up in the real world for cannabis policy. So, to ground our conversation today, we're using a public health framework that you may or may not have heard of, the 10 Essential Public Health Services. We're using this framework today because it reminds us that advocacy in cannabis isn't separate from public health, it is public health. And thinking about it through this lens helps us center people, equity, and community well-being rather than just regulation or profit. So you may ask, what is public health? Introducing public health very quickly, as defined by Charles Edward Winslow, who I'm a little biased towards because he started Yale School of Public Health. He defined public health as the science and the art of preventing disease, prolonging life, and promoting health through organized efforts and informed choices. This definition sounds like a lot. It really makes you think of traditional sides of public health, like health surveillance, health regulation, and outbreak response. Health surveillance, such as tracking disease and trends over time, regulation, such as enforcing food or water safety standards, and we know what outbreak response is. We have all lived through the last 5 years. But it also can look like community development, such as supporting safe and affordable housing or even access to green spaces, or structural equity and advocacy, such as advancing policies that address racial health disparities or expanding access to care in historically marginalized communities. At the end of the day, public health work is to protect, prevent, and promote health in ways that address the full spectrum of people's lives, not just in clinical or research settings, but in neighborhoods, workplaces, policymaking spaces, and communities. In fact, a core component of getting a public health degree is applied practice experience, which revolves around community work and community action. So now that I introduced public health broadly, you may be asking, where does cannabis fit in? When we look at legalization, we know that we've been here before. We've seen what happens when drug markets emerge without strong public health guardrails, whether it's tobacco or alcohol. These patterns are very familiar: rush rollouts, inequitable access, and inconsistent safety standards. The harms often fall hardest on the communities that are the most marginalized and sometimes even targeted by these companies. So how we move forward with cannabis matters. A public health lens helps us do better. It pushes us to think beyond criminalization and beyond profit, and instead ask, how do we ensure safety? How do we reduce harm? How do we promote equity? And how do we center the needs and experiences of the communities most impacted by prohibition? Approaching cannabis work through a public health lens allows us to see the full arc of the drug policy parabola, which is in the middle. It shows us that the greatest harms often come at the extremes. When a substance is overly prohibited or overly commercialized, public health helps us find the space between, where we can reduce harm, expand access, and build systems that actually serve the people in need. Public health helps us see the full picture. It's not about numbers, it's about people, communities, and the systems that shape their lives. At the end of the day, the core of public health isn't anti-cannabis, it's pro-people. And that is exactly the goal when we talk about equitable legalization. So now to bring us into today's framing, I'm now going to introduce the 10 public health services. This framework outlines and looks like what public health is in action. It's used across the country by health departments, researchers, educators, and community leaders to improve public health systems. In fact, this is the figure that greets almost every public health student on their very first day of class. So if it is your first time seeing it, congratulations and welcome to your first unofficial class on public health. The services are grouped into 3 core functions: assessment, which you can see up here, policy development down here, and assurance on the left. At the center of this model is equity. It's not used as a buzzword, it is a guiding principle for the work that we do in public health. Assessment includes things like monitoring health data, identifying health disparities, and investigating emerging risks. Policy development is about using information to inform public health actions, crafting policies, public education campaigns, and regulations that reflect community needs. Finally, assurance is making sure that people actually get the services that they need. This includes linking people to care, supporting a well-trained public health workforce, evaluating programs and their effectiveness, and ensuring that essential services like vaccinations, screenings, and clean water are accessible to all. Together, these services work to build a system that's not just reactive, but proactive. It's focused on prevention, protection, and community well-being overall. The truth of this is that many of us are already doing this work, whether we are in research, advocacy, clinical care, or policy spaces. We are often advancing public health, even if we do not call it that by name. So, bringing cannabis into this, I view that cannabis fits almost perfectly into this model. The issues that we are addressing, like access, education, regulation, harm reduction, and community repair, map almost directly onto the essential services of public health. Breaking this down just a little bit farther, assessment can include tracking cannabis use trends across populations, examining how and why people use cannabis, and identifying disparities in access to medical cannabis programs. Under policy development, that can look like using the data that we have to craft evidence-based policies like social equity licensing programs, public education campaigns, or even to help decriminalization efforts rooted in community health rather than punishment. Under assurance, we are talking about ensuring people have access to safe and regulated products, that cannabis education resources are reaching communities most affected by prohibition, and that we're building a workforce from dispensary staff to policymakers that understands public health and equity around cannabis. As I said before, a lot of us are already doing public health work, whether we call it that or not, and framing cannabis work, particularly legalization efforts through public health lens allows us to name that work, legitimize it to outsiders, and connect to a broader infrastructure that can help support and sustain it. It's not about rebranding, it's recognizing that the equity-driven work that we are already doing is essentially public health in action. The framework helps us communicate the work that we do more clearly, especially in spaces where cannabis is misunderstood, dismissed, or overly politicized. It also helps us build stronger cross-sectional partnerships and push for smarter policy. Because at the end of the day, we're not just talking about cannabis, we're not just talking about substances broadly, we're talking about people, systems, and health outcomes. If you do not believe me yet, let me show you what this could look like in practice. I pulled out 4 of the 10 essential services. I did it randomly, so I did not cherry pick these ones, and I matched them with real world examples. So starting with investigating, diagnosing, and addressing health problems and hazards that affect the population. That's spotting and addressing risks in the cannabis supply or how laws are enforced. That's being able to say, hey, maybe we see that pesticides might be different in this state or another. It's work that we're already doing. Strengthen, support, and mobilize communities and partnerships to improve health. That's working with advocates, patients, and businesses as well as organizations to push for more just and responsive cannabis policy. You're here today, you're already doing that. Build and support a diverse and skilled public health workforce. That's essentially just building skills across the cannabis workforce, from business owners to bud tenders. If you are on the ground talking to your bud tender and informing them of education that you know that they might not, that's doing the work. If you are talking to business owners, talking about how they can have more evidence-based or even just a more educated consumer base, also doing the work. Finally, assuring an effective system that enables equitable access to the individual services and care needed to be healthy. Helping people access medical cannabis, helping people navigate the system, connecting people with services that support well-being, even just educating a friend on a better way to use cannabis, a safer way to use cannabis, or even just using cannabis instead of whatever. So I really appreciate looking on the left side, and those are really jargony. I don't go around saying this is what I do. I use language on the right, and we use language on the right. So it's just that language shift of understanding that we are doing public health work. So thank you for sitting through what I like to call a crash course intro into cannabis public health. If this was your first day of public health class, you are doing great. And honestly, based on the work that many of you are already doing, you're already public health practitioners just without the fancy MPH at the end. Now that we have walked through the frameworks, I'm really excited and honored to turn things over to the real experts, our speakers, who are putting these principles into action every day. First up, we are diving into assessment with Jim and Jane, who work at the intersection of cannabis research and public health communication, tracking health trends, evaluating risks, and helping understand what the data is really telling us. I will hand it over to Jim.
Thanks, Meredith. This first slide, I really want to kind of hammer home the intersectionality that Meredith was just touching on. Within public health and within really all policy decisions, we really talk a lot about evidence-based policy, as Meredith had said, and the assessment and surveillance sections of the public health functions can do this through additional examples such as measuring the efficacy of public health communications, implementation science to measure the impact on health outcomes from specific policies, measuring equity and ownership in the industry, as well as access to cannabis and opportunities within the industry, monitoring health trends over time, identifying potential areas of improvement based on the stated goals of each essential function. So really in all aspects of this, you'll hear it from each speaker following of how intersectional all of these aspects are, and specifically assessment and surveillance, and to continuously bettering our work within the public health space and the cannabis industry. Next slide, please. So specifically related to assessment and surveillance, we have certain types of research. It is incredibly important for us to study geographical, race, gender, and sexuality and income breakdowns within public health, within our research, to help identify disparities that may be occurring so that we can address them and help fix them. Having these targeted interventions certainly is a core aspect in any public health initiative. We also have needs assessments for particular communities to understand what they may be lacking that provide certain barriers to addressing health outcomes. We also have epidemiological analyses to monitor health trends. I think this is an important breakdown to have within this to distinguish between things such as longitudinal study designs as well as cross-sectional study designs. Longitudinal certainly will infer slightly more causality than a cross-sectional design, as cross-sectional is just a snippet of time, one time point, where longitudinal will be multiple time points, such as our longitudinal registry study at Drexel, which has a baseline interview, and then we follow up every 3 months to collect data based on health trends and outcomes. And finally, for this slide, we have implementation science. This is a very new field of research within public health. And it's something that is severely lacking really within all policy decisions, but specifically within cannabis. And it's really about figuring out the true impact that a policy has on health outcomes. It can help eliminate noise and confounding variables by controlling for them and really helping us to understand what the true impact of a policy is on health outcomes. Next slide, please. This is really important to understand, this slide on social determinants of health, as to what the full depth of public health work that we are looking at to address. Whether it's economic stability, neighborhood or physical environment, education, food, community and social context, as well as how people interact with the healthcare system. There are so many different barriers within our society today that have been built and are not necessarily always intentional, but it's important for public health professionals, especially within people in the cannabis space, to really understand the depth and breadth of these determinants of health. This will allow us to help better explain or understand why certain disparities may be there, whether it's racial, whether it's gender, whether it's income, to help us really address and fine tune our interventions to better serve the communities that we are looking to help. We often talk about within medical cannabis contexts about cannabis being another tool in the toolkit for medical providers, such as doctors or nurse practitioners, people of that nature, to help address certain health conditions. Within Pennsylvania, we have 24 different qualifying conditions within the Pennsylvania program. And it's really important for us to address this. And public health professionals, I believe, can take a note of that, where cannabis can be used as another tool in the toolkit to help address those social determinants of health. Moving forward into issues in interpreting research, this is really important for us as public health professionals and as cannabis professionals as well too, to understand the difference between causation and correlation. I know that this is something that is certainly brought up within a lot of major news media today. Correlations mainly tell us what needs to be studied further. These can help identify potential issues or even potential benefits depending on the hypothesis, the data collected, and the interpretation of the data. Researchers will often use language like cannabis may increase or decrease the risk of a certain condition, or the data suggests that cannabis does X, Y, or Z. It's important to know that in these moments when they're using this kind of iffy language surrounding it, that their own biases are kind of being interpreting in it. I'm a medical cannabis patient myself. I use cannabis to help get off opiates. So being able to kind of definitively say from my experience definitely gives a leg up in terms of helping to interpret the research, but also being aware of who the authors are of particular research can help you understand what that research truly is saying. I would also say in terms of statistical significance, it's important for us as general community members and members of the cannabis industry to understand statistical significance. Essentially, it's just saying beyond chance, this result is probable. Researchers like to use typically a p-value or probability value of 0.05. That means within a 95% chance that the result that they're finding is accurate, but there still is that kind of 5% chance of something else explaining the observed result of the study. Can we actually go back a slide, Meredith? Yes, so to limitations of the study. Acknowledging limitations of the study, it's actually one forward. Yeah, this one. Limitations are an important thing to acknowledge within research and the assessment and surveillance aspects of the 10 essential functions. As not acknowledging is a disservice to the reader. I'd like to use the American Heart Association study as an example. Looked at about 4 million people who use cannabis, primarily smoked cannabis who had an increased risk of heart disease as with it. But that study did not control for family history, diet, or exercise, three of the main causes or kind of confounding variables that were not controlled for within that study. So it's important to really acknowledge that as a researcher, but as well as someone who is reading research and interpreting research to help inform policies that you're looking to put into place. Understanding what those are and trying to find additional research or ask additional research questions and then studying it can really help complete and give a better information for informing interventions moving forward. Next slide, please. So now I want to get into the main barriers to cannabis research, namely being the Federal One Schedule, the Schedule 1 designation of cannabis. Essentially, what this has done to research is that it disproportionately funds research into the harms of cannabis use. And from my personal experience, it really has created a significant bias amongst the researchers that are out there that are really looking to have research being funded, as they will primarily only fund or have a bias towards funding research into the harms of cannabis. I'd really like to kind of introduce a concept of cannabis is not a monolith, nor is it a panacea. There are over 60 different cannabinoids and over 100 different terpenes, as well as other chemical compounds within cannabis that make it really unique for us to be studying. Different strains, different forms will have different potencies. So dosing is incredibly important, but research is very limited in this area for us to truly know what is going on with a particular strain or combination of cannabinoids and terpenes. So by saying that all cannabis does this, well, what types of cannabis were they consuming? What forms were they consuming? Is really important to the research, the assessment aspect of the public health functions. Another barrier is that it really restricts research institutions to being non-plant touching, requires us to put in investigational new drug applications, which can range from 250 to 300 pages of safety data, of protocols per each chemical compound within cannabis. This is incredibly difficult to do, but still necessary to do to maintain the safety of the research, but as well understanding that the entourage effect, the idea that a cannabinoid plus a cannabinoid can have an enhanced effect over an isolate, makes it very difficult to do research and very tedious to do research. So it can take a lot longer to do. There's also a barrier in terms of where cannabinoids and terpenes can be sourced from. And we're also not allowed to study and be plant touching with any commercially available products. So that can be a limiting factor within the research as well, too. Furthermore, universities have become incredibly risk averse to cannabis research to protect their own federal funding that are not related to cannabis in any sort of way. And industry-funded research is not seen as credible due to a profit-based bias. Within Pennsylvania, we do have a system where grower processors are allowed to partner with research institutions to fund their research. But we do have degrees of separation between the funder and researchers, and I believe that this is incredibly important to future programs that will be involved in providing industry-based funding to researchers to ensure that bias is not in it. Next slide, please. So as we talk about harm reduction within public health, one reminder that I would like to give to people is that not everyone within public health does share a harm reductionist viewpoint. However, I like to pose these questions within it because I think it is fairly relevant to people within the cannabis industry. And they need to be posed as questions because they do need to be researched further. Is the unregulated hemp market posing a threat to the legitimacy of hemp in the cannabis movement? We often talk about safety testing for contaminants such as heavy metal, pesticides, mold, synthetic cannabinoids, and the byproducts of the chemical processes for creating synthetic cannabinoids. However, secret shopper studies have also found that regulated markets also have an issue with contaminants as well. So kind of thinking about what might be the solutions to this is stricter regulation or auditing authority of testing companies, really incorporating consumable hemp products into the regulatory frameworks to meet the same safety standards, studying that further and what impact that would have on it. And then we also talk about kind of some other kind of public health concerns, such as smoking as a threat to public health. Certainly using other forms of cannabis can help limit that. And then as well, driving while impaired. How do we approach that, given that there's a significant disparity in how long someone tests positive for cannabis use versus the impairment window for you actually being impaired while driving a video. I really want to kind of bring it back to limiting harms and maximizing benefits as the ultimate goal of both research and public health practice. We'll move to the next slide, please. And really kind of driving this home as a harm reduction tool throughout research and assessment and surveillance, limiting the harms, maximizing the benefits. We have the idea, such as cannabis as a substitution tool for alcohol, opiates, benzodiazepines, other prescription medication with much more harmful side effects. Certainly much more research is needed to validate this. But revisiting kind of one of the initial topics that I had proposed was it's just another tool in the toolkit for healthcare providers and public health professionals as well. And really kind of understanding that cannabis is not a monolith, nor is it a panacea. So now I'd like to transition into one research study that a Drexel researcher did, talking about tax revenue for public health services, public health education, as well as researchers, as we'll see on the next slide. So this study was done by an implementation scientist, as well as a former colleague of mine while I was a student at Drexel, on earmarking excise taxes on recreational cannabis for investments in mental health. This is kind of a great strategy for public health professionals and policymakers moving forward, and how research can help inform that. Seeing what a 25% allocation of the taxes could do for it. Colorado with a 10% increase, Washington with an 11% increase, and kind of understanding where those tax dollars can go. Great example of this is in New Jersey. They allocated 70% of tax revenue to communities who have been disproportionately impacted by prohibition and criminalization of cannabis. And additional public health studies would really help identify where the allocation of revenue could go over the coming years, as well as to measure the efficacy of those programs moving forward. So now I'll pass it along to Jane, who will be taking over one more slide here on my end, apologies. We have key research activities at Drexel. We have a longitudinal registry study monitoring health trends of cannabis patients. We also have a controlled use of cannabis study, which is studying the rules and rituals of cannabis patients, of how they control their own use, how they limit the harms and maximize benefits, similar to Alan Zinberg's drug set and setting theory. We have a clinical core building towards studying the entourage effect, as well as an observational study into tolerance breaks. We have additional public health pilot studies, as well as clinical pilot studies, and we work through dissemination through our speaker series, community events, as well as professional conferences. And after that, now I'll pass it over to Jane Allen.
Thank you so much, Jim. And thank you, Meredith, for queuing us up. Hi, everybody. I'm Jane Allen, and I wanted to share just a little bit about myself with you so that you can understand where my insights are coming from. I've been working on public health mass media campaigns for the last 25 years. There are some examples of them on the screen. I'm also doing cannabis and tobacco health policy research, and I'm committed to dismantling systemic racism within my spheres of influence, and I'm grateful to be here with you. Thanks, Meredith. So I wanted to highlight just a few things that I think we need to think about as we reflect on a people-first approach to cannabis policy and research that supports public health. So first, we need to seek to disrupt and dismantle racism wherever we see it. Racism undermines public health, and it's very important that we do that work. Second, we need to center science and respect and avoid centering fear and shame, which is sort of a conflict that we often see in public health. And I'll show you some examples of that. Third, we want to promote systems change that support people in making healthier choices, and we want to de-emphasize rigid, controlling, and punitive responses. And fourth, this people-first approach won't be created by corporations. We need to keep it in mind, and we need to be part of a movement to build the change we want to see and fight the corporations trying to move into the space. So I'm going to give you 3 examples of community information needs. And I thought that these 3 examples would sort of highlight the things I shared with you on that previous slide. So the first example is from Colorado. The second one is from California. And the third is from a National Parabola Center study. And this is the example from Colorado on screen now. So I was the evaluator for Colorado's retail marijuana education program, and that launched in 2019. It was a good, I think it was an example of a really well done campaign. The woman on screen is Meg the Bud Tender, and this particular ad filled a public health need in that all of the messaging about storing cannabis, safe storage, nationwide at that point was put your cannabis up high or out of reach of children. And this ad like really cleverly and charmingly makes the point that putting your cannabis up high isn't enough because kids can get into anything. And so she recommends that you lock your cannabis up. This ad was super effective. By the way, they put serious money behind it. Colorado put $900,000 behind the consumer campaign, I should say. So it was this ad and an ad about respectful use of cannabis in public because some people don't like the smell. And another ad was about safe consumption of edibles, like, you know, what you should plan for. Clear your day was the basic message. So Colorado really focused on delivering to consumers the kind of information that they felt was unbiased and respectful and honest. And it was very effective. And you can see on screen that people who saw this ad were 3 times higher to say that they intended to lock their cannabis up than people who hadn't seen the ad. So effective and well done. However, at the end of the first year of this campaign, which showed so much promise, and that's pretty early on in the life of a media campaign, there are many changes that you wouldn't expect to see until you invested more time in the campaign. But Colorado decided to defund the campaign. They felt that it wasn't anti-cannabis enough. It was the legislature that took the money away. They gave the money instead to the Colorado School of Public Health and Meredith. What they did with it was they created some artwork. They funded artists to make art about cannabis. And they were definitely like leaning into the fear and psychosis and suicide and that kind of thing. And so this is called Young Man Experiences Psychotic Episode After One Dab, a sculpture. And so where we see the previous ad, which was on television, it was shown on digital, that ad reached 30% of all Colorado adults and had conveyed clear information to them, and we saw that it had an impact. This sculpture is in an art studio. I don't know how many people saw it, probably not the million people that saw the other ad. Moreover, this, Meredith talked about how public health is an art and a science. If this is an art, it's certainly not a science. This is not how to communicate to people. There's no nuance here. If anything, it's a message, a fear message. Don't use cannabis or this will happen to you. It doesn't deliver the kind of information that people need to make good decisions for themselves based on who they are and their own risk levels. And in my next example, I'm going to get into it. It sort of flows into this next example from California. So last year, the California Department of Public Health convened a committee to study high potency cannabis, which as you probably know, or as you may know, is increasing dramatically. The potency of cannabis products is increasing dramatically. And when we start to see negative health effects from cannabis, it's at those very high levels of potency. So California wanted us to provide recommendations about how to mitigate those harms. As part of that, California is required to provide a handout to be available at all cannabis stores in the state. And we provided a proposed brochure for them. And now the law says it's one page. We provided a double-sided page. So I'll show you this and I'll show you one more page that we recommended to them. And but to go back to the first one, what I really liked about what we did, and I don't love everything about what we did because it's committee work and I had to make compromises on some of the language and some aspects of it. But what I really loved that we did was we talked about tips for a safer and better experience. And I thought that we did a good job acknowledging the role of pleasure and showing care for the individual. Like, we don't just want to avoid a bad experience. We want you to have a good experience. Like, we care about you as a human. And then this is the backside of the trifold. This is a trifold. Yeah. So a couple other things I really liked we did was we invited people to consider lower THC products and to ask their retailers for lower THC products. And in the section on mental health, we gave people information so that they could assess their personal risk for precipitation of or exacerbation of a mental health condition sparked by high potency cannabis. And we gave them the information they would need to determine if they were at risk or how to use cannabis in such a way that they would be less likely to spark a problem for themselves, like using lower potency products, using products less frequently, for example. Well, California, I'll show you on the next slide. This is what they decided to do instead of what we recommended. It's not terrible, but it's not great, I don't think. I think it's ugly for one thing. I think it's hard to read. And I think it's part of communication is like ease of access of the information, which is partly being easy to read. But they didn't give people information to help them assess their risk. They really just say, like, if you use high potency cannabis, you can, you can have these negative outcomes. And they also emphasize negative outcomes in the centerpiece of the flyer, which to me, the general tone of this is one, it's punitive and it doesn't help people use their own agency to make decisions about use. And I actually think it is a disadvantage, a disservice to public health when you put people in that position where they don't have the information they need to make decisions. So last example, I want to be mindful of time and I'm almost over. This is the National Parabola study that I worked on with Parabola a couple of years ago, I think now, and we're still really working on it. But I want to highlight what people want, who they trust to create good policy. And so we surveyed adults nationwide, and we found that people really want cannabis policy to be created by people with lived experience, people who use marijuana, and people who are working for social equity. And they explicitly don't want it to be created by companies with a history of racism and exploitation. So Parabola, with this information, made a great media campaign. The next slide, you'll see Chelsea was a part of it. She had a really fantastic and impactful ad. And on the next slide, you'll see some data from that study. I know this is a lot, and I don't want you to feel like you have to look at everything, but I'll just give you a little guidepost, which is the pictures that on the left-hand side show whose ad these messages came from. And the main thing I want to point out is, so we did an experiment where half the study sample saw no ad and the other half saw the ad. And then we asked them their beliefs about cannabis policy afterward. And you can see the first bar is those who didn't see the ad. The second bar is those who did see it. And you can see that everybody who saw these ads was so much more in support of equity-focused cannabis policy. And we see a large proportion of people who in the gray bar, either don't know or don't care, haven't got a firm fixed belief. And so I wanted to leave you with this because it's a really hopeful opportunity for us to speak up. People do care about this, especially when we explain it to them. When we talk about what matters to us, people hear us, and there is increased support for the kind of things we care about. So with that, I will turn it over to Chelsea.
Thank you so much, Jane. And thank you so much again to Parabola Center for having us here. I'm going to talk a little bit about crafting the policy. I am the Executive Director of Marijuana Justice. You'll see right here that our mission since 2019 is to facilitate the repair from the impact of the war on drugs for individuals and communities, specifically in Virginia. And we organize with a coalition, which includes youth, students, public defenders, equity advocates, to really promote safety specifically for small business inclusion and future cannabis markets in Virginia. So here's a little bit about us, and our main hometown is right here, Richmond, Virginia, the capital of our Commonwealth. So I really wanted to start out by sharing why I'm here as well, which is how I got here. And we can go on to the next slide. I was a social worker for over a decade. And unfortunately, I was always having to be the intermediary between my clients, my families, and certain departments that were providing services. So what I kept coming up against was that somehow my client's behavior was actually being criminalized and therefore unable to really receive services and receive benefits or just receive anything that would allow them to continue to survive. So when we're creating cannabis policy that's people first and really crafting from a public health model, it's important to remember that criminalization is part of our public health crisis. I just really want to mention that our public health crisis that has to do with criminalization comes from every single department. And so when we're looking at, we know that it's Department of Corrections. Many people understand that the war on drugs has caused a mass incarceration. We look at child welfare. Here in Virginia, we have legal marijuana to consume for adults. We can grow 4 plants per household. We can share, but there's still a policy that says even with legal responsible use by adults, we can still have your custody and visitation impacted because of cannabis. The Department of Labor, Behavioral Services, which is our mental health, education, economic development, when we look at some of these zoning laws that are coming up around cannabis, institutions of healthcare, agriculture, housing, transportation, and the list really goes on, right? So when we are looking at crafting policy in a public health sense for cannabis, we have to remember that there is already cannabis policy created in these departments. I'm going to say this again. There's already cannabis policy created in all of these departments, which really means that we have to do the look back and make sure that we're repairing that policy to make sure that there's access for everyone moving forward. Next slide. So people-centered policy really starts and ends with people. So I really appreciate Jane's lifting of the study with Parabola Center. That was such a great experience. I was even overwhelmed with the way that our certain messages really resonated with people to change their mind. And when we change people's minds, we change people's actions. So when we are crafting policy, we also have to check in on our people-centered and people-first values and beliefs. Here are some of our values and beliefs with marijuana justice. So it's really looking and understanding that some things will need to be repealed and some things will need to be reformed, and really interrogating Like we saw the causation and correlation and knowing that we still need more information. And there's some information that we just know that we need to change immediately, right? So we can also look at our educational values versus punishment values. So that goes for adults and for children. Looking and really interrogating your own values around access, around people who use drugs in general, that deserve safety and care. Cannabis is not an exception drug, and we really use cannabis as a model for how we are addressing the drug war, particularly in public health, when we start looking at other drugs and how we treat people that use drugs, remembering that cannabis is that gateway to criminalization. And so how are we also relearning and unlearning some things from our own drug war experience? People's health is more valuable than profits and revenue. As public health experts, and talking to a room of people that value public health, I know that it can be hard to put a numerical value or a money value on people's health. But when we look at the social determinants of health and how long people can live, how healthy they can live, we know that that creates a better society for all, which is way more valuable than profits and revenue. Community care should not be criminalized, and there is no data without people. There's so many different ways that we can collect our data and understand, but just making sure that the only time that we're trying to assess something, which is why I really appreciate Jane and Jim and their explanations, is that it's going to take more than just looking at the numbers. And just remember that compromising on policy really means that compromising on our health. So when we talk about people first, it's like, who are the people? How do we organize people? How do we see groups of people when we are developing policy? And it's going to be important that we do a little community organizing in our world because we have to be able to engage everyone from the core group all the way to the full community because our public health really does impact all of us. And if we do not have some sort of organizing infrastructure, then it is going to be really hard to say that your policy is people first if you didn't have an infrastructure for people to engage and create access. So this is a very simple circle. I look and I show people all the time of how to identify the groups that you're working with. Is it your core? One or two people, the folks that have the data, that know the problems, as well as people that know the policy and know your local codes, your municipal codes, your state codes, those that are committed, right? Those that may not be writing the codes or the new policy, but they'll review it for you. They'll say, hey, this is what's missing. Looks good. Your congregation, right? That's back to my coalition that we work with here in Virginia. And then it goes even larger to the larger crowds that are directly connected to us, that can reach us, that can DM us, right? That might sign our petitions, that might follow you on social media. And then there's a larger crowd that might not even have the direct access to you. It's just one of those 1 to 6 degrees of separation. And so it's really important to be able to recognize, hey, who's in our core, who's in our committed, and how are we still reaching all the way to the full community? When we're creating policy, we're really just validating the community knowledge if we're doing it in a way that is data-centered, evidence-based, that is with a harm reduction, as well as if it's done with people. So looking back at the equity wheel of public health, at the policy part includes communicating. So I'm really recommending that you work with great people like Jim and Jane to be able to share and translate some of the data so that people can see themselves and validate, yes, this is what's happening. Yes, this makes sense. Narrative creation at 8th grade reading level. I'm going to say right now that some of the things that Jane put on the screen, I couldn't read just because it was overwhelming, and I have a master's degree. And that right there was inaccessible for me. Language justice, digital print access, visual accessibility. We really saw some great examples in what Jane showed us through the Parabola campaign, as well as through the structure piece that really didn't communicate anything but fear. We want to make sure that we're organizing, create spaces that can continue to build on. And I said, yes, an actual space, whether that's a digital space, a community space, somewhere where people can find you, somewhere where people can come back to, because that creates a habit, right? And we really want to engage people so that they know it's not just right now. And I really and share with people that you've got to prepare for sabotage. Welcome to cannabis policy. Welcome to the world of pushing back and ending the drug war, because I have cops and corporations, but it can be many folks, right? We talked about some researchers. We've talked about other folks that will come to disrupt equitable progress. So it's important to identify those institutions now that you know will have some issues and concerns. And as we talked about in the beginning, already go and finding their cannabis policy and figure out and predict how we can move forward in the way that causes the least harms and maximizes the benefits. So validating the community knowledge again, as we are continuing to mobilize, as I mentioned before, that this is an ongoing process. When you are developing policy, please know it's not a one-time thing. I can say right now that there have been thousands of housing bills. There have been thousands of transportation bills. And proposals. And that's also how it's going to be in cannabis. I'm in Virginia. We still don't have a regulated adult use market. I have legislators coming to me and say, Chelsea, we're not done with this cannabis thing yet. No, and we won't be. And it's okay to start to socialize that we are here to stay, to continue to make our communities healthier and safer. And we want to make sure that we win. So we've got to be able to do this long-standing work. You know, in the public wheel, we had create the policy, champion the policy, and we're going to win. I wanted to just do a very simple, hey, what your process could look like is you're going to create a draft for a policy. You're going to check in with your people, whether it's committed all the way to the congregation or to the community, and you're going to have to draft it again. You're going to check in, and then you're going to predict that wheeling and dealing of sabotage, as well as just people trying to get their needs met. Right? I can read a cannabis policy and tell you what type of stakeholders wrote that policy just by seeing how inclusive or exclusive it is. So go ahead and predict that so that you can pivot in a way that is still serving your community and reduces the harm. Right? I tell people go in asking for everything you need and be prepared for what your compromise and your non-negotiables are, because the negotiations are coming. So predict that wheeling and dealing, pivot and push. I'm just really excited that people are looking more of what the policy development infrastructure is. A lot of times we have really good data, and a lot of times we have a really big problem that we all know what it is, but it's the infrastructure of the policy development that really we can continue to work on, particularly involving the community. That will continue this and sustain us forward. So I really appreciated what Jim said as well, which is really making sure that we limit the harm and we maximize the benefit. So if you stick there with policy development, then we'll be sure to make the win. And the final piece is really, let's just look at the data on the impacts of prohibition. These are just some questions and some things to think about. What do we collect now? How can we demonstrate the problem? What else do we need to know from the past and the future? Remember, cannabis prohibition harm has been happening a long time. Create timelines and transparency for your data. Create a mechanism for community input in your legislation. Right? There has to be some sort of process for the people within your legislation, and create that mechanisms for updates per the data, whether that's every 6 months a report is out, annually the report is out. Is there an ongoing standing commission to review these? And as we go into the policy and solutions, make sure that you're continuing to review what others have already learned. A big shout out to Parabola Center's anti-monopoly toolkit. It goes through actual policy language that you want to avoid as well as you want to add, and support a diversity of experts in and outside of institutions. And I'm really just leaving folks to remember, if it's too easy to create a policy, chances are you probably left someone out. And that's all for me. And I'm going to pass it over to Tauhid.
Thank you, Chelsea, and hello, everybody. Thank you so much for having me. I'm going to talk about, and I'm going to wrap this up a little bit in terms of trying to address the three core functions of essential public health services. My part being the assurance part, but I'm going to talk a little bit about what everybody on this panel has mentioned in terms of assessment, in terms of policy developments, and assurance as well. So a little bit of background on me. My name is Tauhid Chappell, pronounced he, him, representing New Jersey. I've been a medical cannabis patient since I learned I qualified to become a patient back in 2012 when I had my first job as a social media producer in Arizona, of all places. Yes, in 2012 in Arizona, they had legalized for medical use. It was a shocker to me, but it was such a eye-opening experience. So that's how I entered the cannabis industry as a patient, so to speak. I have an autoimmune deficiency disorder called ulcerative colitis, and cannabis is used to help my inflammation and stress. And so my background is in media and journalism. I've been a journalist since I got my first beginnings as a social media producer in 2012, all the way up until my last previous job, which was focused on media policy and media advocacy. I also worked in a dispensary as well in Philadelphia, the second dispensary to operate in Philadelphia. It was owned by Grassroots and then was bought out by a large multi-state operator called Curaleaf, which some of you may be familiar with. I also, while in Philadelphia, organized two cannabis conferences that talked about the intersection of cannabis legalization and how the media can do a better job at educating and informing the public and the impacts and outcomes of legalization, especially as it pertains to people who have been impacted by the war on drugs. And then in 2020, during the pandemic, I moved from Philly to New Jersey, back to my home state of New Jersey, and I worked on a coalition that included equity language within the CREAM Act, which is the current law under New Jersey that legalized cannabis for adult use. I was also tapped as an adjunct professor at Thomas Jefferson University, where I take students virtually throughout the country and look at the impacts of outcomes of equity movements in various states and talk about the things that advocates advocate for cannabis legalization, like Chelsea and these other panelists had mentioned, and really what the realities and the impacts were from this advocacy, and did advocates get what they want out of legalization. And then after legalization in New Jersey, one of the lead coalition members of our group was tapped as the consultant to begin building out this technical assistance program in New Jersey, the Cannabis Training Academy, which I'll talk about in just a second. And I was tapped as the executive director to help launch the program, which we formally launched in October of 2024. And as you can see down there, I've had the privilege of living around the country and operating and navigating every single state's cannabis legalization as a medical marijuana patient has given me a lot of insight into the future and into what we currently are dealing with here on the East Coast. Next slide, please. So, like I mentioned, I'm just going to give a brief background on the Cannabis Training Academy. The Cannabis Training Academy is housed within the New Jersey Department of State's Business Action Center. So other states might have a small business office or a small business advocacy office. Our Business Action Center includes the Cannabis Training Academy. In its totality, we have 10 levels, more than 60 modules that are taught by various subject matter experts and people who have won cannabis licenses inside and outside of New Jersey. The goal of our core curriculum is to help people understand the application process if they are deciding on getting a cannabis license in New Jersey. It's also a reality check to help people understand if getting a cannabis license is really for them, or if they'd like to join the cannabis industry in some other way, shape, or form or capacity, whether as a worker or starting an ancillary business and supporting the supply chain as well. This program, and I'll talk a little bit about this in just a second, this came after we did a lot of community outreach, a lot of public listening, and a lot of feedback on what the community needs were as legalization was happening in New Jersey and as these licenses were starting to become available. And one of the biggest things that we heard from the community was this needs to be accessible. And so to meet that specific need, we made sure that this program is all online. As long as you have working Wi-Fi or working cell phone signal, you can operate and log into this program online through your phone, your tablet, or your computer 24 hours a day, 365 days a week. You can look us up at cta.nj.gov. You can learn more about our program. And while I will say this, while it's technically for New Jersey residents, we trust people say who they are, and you can register as a student at no cost to check out our curriculum offerings. And you can also see our course catalog at cta.nj.gov. And so also to also address some of the needs from community members when we were doing our outreach, we also made sure that not only is this online, but for people who have different educational needs or learning needs, we made sure that the program is also accessible in terms of audio, in terms of scripts, in terms of Spanish translation as well, because we know that Spanish is the second most spoken language in New Jersey. And then we also make sure that we do virtual instructor Q&As with our instructors on a weekly basis, and we're organizing in-person events too to meet people where they're at as well. Next slide. So as part of the assurance, I want to talk a little bit about how we got here. So Chelsea and the other panelists had mentioned, defining the needs. When New Jersey legalized cannabis, one of the biggest things that community people had asked for was education and information. People were interested in getting a cannabis license and participating from the business perspective, and they wanted to understand how could they possibly get a license. And so the development of the Cannabis Training Academy was created when we started to hear people talk about, we need more information, we need more information. How can you bring this to us? And it wasn't just about the cannabis licensing in specific as well. This was actually also about just business 101. A lot of people did not have any business degree or business background, but they still wanted to participate in the cannabis industry. And so a lot of the technical assistance that we provide is not just specifically cannabis licensing, but how does perspective. And these are things and ideas that could be modeled and replicated from a public health standpoint too, because education and information is vital. And that allows people to make the best business decisions for themselves, whether or not they want to join the industry or they want to be a consumer or patient and understand what they're participating in. And so when we were doing our outreach and making sure that we were hosting town halls, we were going to specific events, we were showing up at community centers, libraries, we were tabling, being part of panels, moderating, we were making sure that we were getting audience feedback and community feedback as we were developing the curriculum as well. And one of the things that we wanted to be intentional about is that we knew that from a equitable standpoint that we wanted to make sure that we were building the next cohort of diverse leaders and diverse workforce as well in New Jersey. So we made sure that we showed up intentionally to specific locations, specifically that were places that had been designated as the most impacted by the war on drugs. We made sure that we were reaching out to specific organizations and specific places and people like the Black and Latino caucuses as well, so that we were getting the word out to specific demographics of people. We also made sure that we were showing up to various universities as well to let students know that this was an opportunity for them to participate as well as they were getting ready to enter the workforce too. And as you can see at the bottom of this screen, our impact is starting to show since our launch in October. We have now reached more than 1,200 students who have registered throughout the state of New Jersey. More than 51% identify as women, and within that cohort, more than 47% identify as Black women as well. We'd like to thank the sororities specifically. I think our CTA program got circulated around the Divine Nine pretty quickly because Black women as registrants definitely boosted as soon as we launched. And so we were intentional about that. We wanted to make sure that we were reaching out to specific groups of people, and that is showing in our student population as well. Also, from a Latino perspective, Latinos make up the third most amount of students from our program as well. Again, we wanted to be intentional about Latinos as well. And we wanted to make sure that they knew that we were providing this program in Spanish well for those that were Spanish speaking too. We wanted to be inclusive. We wanted to be cognizant of who we were reaching. And so we were making sure that we were meeting the needs from the community as they were defining them with us. Next slide, please. And so this program, like many programs, not just business, but also in public health as well, it should always be evolving. It should always be iterating. And as other panelists had mentioned too, making sure that you are getting public feedback, surveying, outreach, consistent feedback loops are created so that we can make sure that we are meeting the people where they are and making sure that we are expanding our program to meet the growing interest that we continuously see in the state of New Jersey. And so some of the things that we continuously do, we host our student focus groups every Thursday night. And we also host student sessions on Friday mornings as well, so that people can have an option to join us to provide feedback and also ask us questions about the program. We ask people about the bottlenecks. Where are students having trouble going through our program? How accessible is it? Is the teaching and the learnings easy to comprehend? Is there anything more that we could be providing? We are making sure that we're circling back to students who may have started an account but may have not logged in for a couple weeks or a couple months. What can we be doing to continue your curiosity and help you go through this program so that you are more involved in the actual industry? We're also making sure that we are generating credible messengers in our feedback loop too, making sure that the students who are praising us are also spreading the gospel of our program and letting them know, hey, I've joined this technical assistance program. It's no cost. It's online. It's go at your own pace. You can do it at your own time. You should sign up, making sure that we're finding our credible messengers to help us spread the information and meet people that we may not automatically be reaching out specifically to. And then another thing about messaging too, especially from an assurance perspective. When the Cannabis Training Academy was created, it was because we did the initial work of reaching out to community members and making sure that people understood that we were listening and that we were providing a program based on their needs. But obviously, one program being launched does not mean it's automatically not only going to be a success, but it will always be sustained. And so in making sure that we are keeping up with the needs of the community, we're also messaging internally inside government and to lawmakers about the impact of our program. And that comes with two different types of messaging. Internally, as many of you probably know or may be aware, lawmakers like to look at the dollar signs. They want to know what the money potential is of a program or how it impacts their constituents directly. And so we have to talk about the fact that, our program could be a cost creation, or not a cost creation, a revenue creation for the state, because the people who go through our program who decide to apply for a license will not only be more informed, but if they get a license, they'll be able to participate directly into the economy of New Jersey, thanks to the Cannabis Training Academy. And that will generate revenue directly to the state because we help them get to that point. And then messaging to the public too is that we're telling people that because we brought in all these instructors to help us work on this curriculum, you now save money by going through our free program because you would have otherwise spent money having to do consulting with a lot of our instructors or other people in our instructor group, and that would have cost you a lot of money. And so from a cost saving perspective, that is an opportunity for us to message people to say, you are saving money and investing that saved money in yourself through this education. And then on the flip side, if you're able to go through our program, if you're able to get a license and succeed, then you're also going to be providing money into the economy of New Jersey, which lawmakers and the legislature and the governor are going to appreciate and support too. So we have to make sure that we're assuring the public and then we're assuring the people who control the purse that we are doing our jobs and also are impacting New Jersey from both inside and outside state government too. Next slide, please. And so as you heard, we talked about assessment and defining the needs. We did outreach, we did community events, we did town halls, we met people where they were, and we learned about what their needs were. And then we talked about policy developments. People showed up, they said that they needed education. We decided, okay, how can we create this program that meets our educational needs? And what levers can the government pull to make sure that this program is launched and successful? We talked about assurance, and that's not only messaging to the people that we are now live, we're accessible, and we are free, but also messaging internally and saying, if this program is successful, there is a net positive revenue potential for the state that everybody can win. And so when we talk about building and maintaining a strong organizational infrastructure, messaging and communication inside and outside is key because, surprise, as you all see, education needs funding all the time. Even though the Cannabis Training Academy was not specifically written into statute as a law and was not definitively defined in regulations, we are working with our legislature and our regulatory commission to determine how can we continuously get funding and support to not just keep our operations going, but to expand our operations to meet more of the demand of our students and the public. And then we're also determining what are some opportunities for us to incentivize participation too. We want to make sure that people who go through our program understand that there is a added to it, not just a certificate, but what are some other financial or other business support that we could provide by being a participant too, and making sure that people realize that they're spending their time and working with us. What can they get out of this? And then again, making sure that we're accessible and meeting the educational and learning needs of everybody too, not just online, but what other opportunities we can provide to make sure that people who may be hard of hearing or hard of seeing or speak another language can also participate. And then making sure that we are messaging our constituents on the outside and the public to let them know that we exist and that they can participate, and then messaging the legislature and government officials to let them know that we are bringing a value and that they should continue to support us because the needs are being met as the demand comes too. So that is my portion of this panel. I believe that's my last slide too. And so I will pass it back to Meredith to wrap us up. Thank you. Oh, you're muted, Meredith. I'm sorry.
You're good. I jumped the gun. I want to thank all of our speakers for such wonderful talks. I think you all framed the framework, to say it like that, so beautifully. We have received 2 questions that I think we're going to jump into first, and feel free to put any other questions you have into the webinar. If not, I also have other questions prepared for us to talk. So it looks like I'm going to stop sharing my screen for this portion of the webinar and read our first question. Our first question is, it seems that many studies that focus on the health impacts of cannabis focus on consumption by smoking rather than other forms of consumption, eating, drinking, etc. Should policymakers consider the different modes of consumption while considering public health outcomes as part of policymaking?
I can definitely jump in on this one first because I think it was primarily related to my section. I think it should be of consideration. One thing of a strategy that's been used within all of public health is kind of this incentivizing behavior through excise taxes. Personally, I'm not too big of a fan on THC caps or limits and things of that nature. But one thing that has been floated that's an interesting concept is taxing certain forms of consumption, such as smokable flower. Interestingly enough, within Pennsylvania, in the medical program, it is not strictly speaking legal to smoke cannabis, though they take somewhat of a hands-off approach in terms of enforcement. Kind of what you do in the privacy of your own home is certainly up to you. They encourage people to use flower vapes for the flower products. But it's definitely something that policymakers and organizations will definitely need to keep an eye on. But I have seen some interesting work out there, and I believe Tauhid actually had shared some of this about the science of smokability and talking about that there are different chemicals and components within cannabis that are active at higher burning temperatures or high temperatures that vaping flower does not always achieve. So it's something that definitely needs to be studied further in terms of where the true benefits lie, as well as the more in-depth kind of harms, as we looked at kind of the American Heart Association study and the limitations that had. But finding some sort of tiered system, if the harms associated with smoking become further elucidated through research, it's something that will need to be addressed through policymaking eventually.
I'll also just
Go ahead.
I was just gonna say, just as a bud tender too, when I worked in Pennsylvania and Philly, we did see the outcomes of specific policies. As Jim had mentioned early on, patients couldn't even access flower to smoke when cannabis was legalized for medicinal use, despite other research from other states showing that that was an accessibility option for patients, and that patients had the power to decide on what they decided to do with their bodies, with their medicine that they were purchasing. But I think there are some possible value adds to determining the types of I guess, medicine that is available, but at what levels and what price points too, because obviously at the end of the day, price is going to impact patient behaviors too. My perspective is that when I was a patient advisor, that's what they called us bud tenders, is that we made sure that no matter what array of medicine was available, we made sure that patients just knew exactly what they were getting. And that comes down to the education and information, because the last thing you want is somebody who believes that, oh, I'm a smoker, I've smoked this forever, I've used this since I was, a teenager. I can take RSO. That's fine. I've smoked enough. It's like there's a completely different intake and experience from an RSO versus a capsule versus smoking. And so I'm of a belief that patients should have a variety of options that meets their needs, but it needs to also come with a lot of education information before a person purchases it and doesn't realize what they're getting themselves into.
Thanks so much for this question. I saw this in the beginning and I've been thinking about it. So I just want to, when we're asking policymakers to consider different methods of consumption, I want to also just show why it's important to do that and holistic. In Virginia specifically, again, we are legal to grow, share, and consume, but we are not actually able to create our own edibles at home. So that's actually illegal. Like you can't make brownies in Virginia. That's actually, most people don't know that. And our policies, we're not seeing that enforced right now. So it's important to keep our mind open to say, to create access for those other types of consumption methods, right? And then I wanted to just tap on a little bit as we talk about smoking. Remember, when we talk about low income and marginalized communities, those are the folks that are normally possibly smoking the most and using smoking as a method of consumption for a number of reasons, but just making sure that we're educating folks on deterring different ways versus criminalizing or deterring folks from not smoking. I just want to encourage that as we look at public health. And then my other big thing from a policy standpoint, why it's so important to think about other methods beyond smoking is because if we only look at smoking, guess what they're going to do in policy? Copy and paste a policy from tobacco. They're going to go something from alcohol. We love a copy and paste in policy development. So speaking outside of those terms that we know will create innovative ways for people to have access to healthy consumption.
I also will add that I think that research, particularly looking at national databases funded by the government, such as like the Behavioral Risk Factor Survey, the National Survey on Drug Use and Health, need to include more questions about the types of usage. I particularly am on the precipice of submitting my thesis, and I used behavioral risk factor survey data because they specifically sub-question, did you use it as an edible version? Did you use it as a vaping? Did you dab? So it allows us to glean those differences. And while it may be cross-sectional data, so we can't infer causality, it does give us a good glimpse into what populations are using which forms of methods, and then we can start to dive into why and then build policy from there. And then I think we all touched on that. If jumping to the next question, regarding funding research, where can we learn more about how the degrees of separation between the funder and research can be developed, implemented, and enforced?
Yeah, so this is definitely a very good question. And the one state that I think has done a very good job at this is actually Minnesota. They've actually kind of funded an in perpetuity for the University of Minnesota, where it's collected through tax revenue. So it does kind of provide that degree of separation. In Pennsylvania, it's really up to the institution and the funder itself to kind of create that. So specifically at Drexel, they do not approve of any sort of questions that we ask. We really have full autonomy over what we are studying. We do have some members of their scientific team on our scientific advisory board that really just kind of helps answer questions deeper about it. I think this really needs to be developed kind of at the policy implementation level or in passages at the legislature for states that are considering doing something like this. I know that Pennsylvania and Minnesota are two of the rare exceptions. I think there might only be a third or fourth state out there that funds research for this. But when considering it, those degrees of separation need to be made clear. And really the limitation that we find is when we come to publishing our research, where we have to declare our funding sources. So if you're receiving funda from NIDA or the NIH, that's where that would be disclosed, but then as well, industry funding. Everyone really takes that research with an extra grain of salt to that there may be a potential bias in there, even if degrees of separation do exist. I don't really know if there's really any sort of enforcement for this, because it's not really too, at least from my perspective, currently not too big of a problem. It's more just the fact that medical associations like AMA or other kind of big thought leading organizations don't really accept that research because of the potential bias within it. I think it's more about creating new avenues for research to be done outside of the traditional NIDA or federally funded studies that can allow for more balanced cannabis research between the benefits and the harms to really happen. So I would say it's definitely a very complex issue, but I don't think enforcement really makes sense, because people are already kind of dismissing some of the positive research into cannabis because it comes from industry funded sources. But if there are ways that we can create and incentivize these degrees of separation in future legislation, I think that's really the core of the point that I was trying to make.
Perfect. I think if no one else wants to add on, our next question is, there has been a significant increase in the use of medications like Narcan and Suboxone to address addiction and prevent overdoses. I'm curious, are there any current research initiatives in any of y'all's states exploring the use of cannabis as a tool to assist with opioid addiction?
I'm going to look to drop some links in here, but New Jersey and I believe Pennsylvania were one of the early states that allowed medical patients to qualify for cannabis because of opioid addiction as well. And there was some research that was used and cited by regulators to ensure that opioid use or opioid addiction was a qualifying condition. Jim, I'll pass that to you, but I'll look for some stuff from Jersey side.
Yeah, so there's a tremendous amount of interest on our end. What we're finding in our patient registry study, which is essentially where we're recruiting from, we have about, I want to say, 1,150 patients currently enrolled in that. There's not an overwhelming portion of the population that use that as their qualifying condition for opiate use disorder. But kind of going back to one of the core concepts from what I'd presented on was that it's really another tool in the toolkit for it. The research currently is in a very elementary stage, specifically for opiate use disorder. We are seeing a lot of people with primary qualifying conditions such as chronic pain, which is kind of the direct substitute for opiates or as an alternative treatment. I am not a medical provider, so I can't really speak in terms of too much authority with the general consensus for it. But in terms of talking with MDs on our staff, it's not supposed to be a replacement for Suboxone or methadone, but rather as kind of an additional tool for when people are looking to get off of Suboxone or methadone as a potential next step. And that's really where I believe the next portion of the research is headed, but would certainly appreciate to take a look at what Tauhid mentioned to send around for that question.
As Tauhid is looking, I want to put our next question of, have you seen commercial examples of public health prioritization within the consumer-facing industry, especially regarding healthcare integration? How can we more fully recognize bridging this gap?
Could we
Sorry,
ask
Meredith, can
Andrea
you
to say more or?
could you repeat the question? I'm sorry, Meredith. I was looking for my answer. Sorry.
You're good. Have you seen commercial examples of public health prioritization within the consumer-facing industry, especially regarding healthcare integration, and how can we more fully recognize bridging this gap?
I got a link for that actually. Sorry, Jane. I have a quick link I can drop there. So New Jersey actually, a couple cities actually just integrated cannabis within their healthcare systems for government employees at the city level. And I'm going to drop that in the chat too to look at, which is probably the earliest form that I've seen cannabis being formally utilized and incorporated into healthcare for people who use it at the government level. I just dropped that link in for the person who asked that question. The headline reads, 3 New Jersey municipalities will offer medical marijuana benefits to public workers, which is an apparent first in the US. So check that link out. I'll pass it to Jay.
Oh, no. That's great. Great to hear.
And I'll just add on here, I know this isn't, we're looking more from a message of institutions, but really I'm looking for what more community harm reduction groups and their messages, what they put out. I think we can learn a lot from what we're seeing in harm reduction groups and the way that they talk to each other and also talk to institutions.
Perfect. And I know we're running short on time. So I was going to highlight a comment that we got and comment back and then share information. So from this presentation would also be perfect for folks working in the psychedelic policy development. The public health model analysis would be very instructive for us. As a public health person and going into the public health workforce, I completely agree. I think public health is very much siloed into a smaller group that it could be, particularly due to educational limitations. And I think that bringing public health into across different forms of both drug policy as well as housing and environment and community-based health initiatives is a really important thing that we need to work on together as a group across divisions. Sorry, I was muted again. To end our webinar, I want to thank you all for coming. I hope this was informational and helpful, as well as I wanted to share our contact info for each of us, as well as Parabola Center. You can find us at Parabola Center on Instagram. Searching Parabola Center also brings us up. We have a great website with more information and resources, and especially on the parabola of prohibition, which I always like to hype up because I think it is foundational in understanding how we move forward in drug policy overall. Otherwise, I just want to thank you all for coming, and yeah.
I just want to point out, Meredith, too, I just put in the Zoom link for the person who was asking about opioids and cannabis, I think loosely, a journalist in Pennsylvania had actually asked Pennsylvania's Department of Health to share the research that they use to justify putting opioid use disorder as a qualifying condition as a cannabis patient in Pennsylvania, and the Department of Health sent him back a whole bunch of links to current research around that use. So I'm not sure if that specifically addresses that person's question, but I just dropped in the Google Drive link for people to access, and there are more than a dozen research articles around the intersection of cannabis use and opioid use as well. So I think you might find that useful. Happy learning on that one.
I will say that there are varying results and varying access to academic publications, which is a larger issue that we have in academia being inaccessible. But if you if anyone is interested in looking at current research coming out, this is PubMed. I'm going to type it out so I don't say it, but if you go to like PubMed Central or search PubMed, you can easily access abstracts and different ways that you can briefly get an understanding of what the research base looks like. I will say that a lot of these abstracts are even above my head, or not in my particular area, but it does give you the ability to kind of dip your legs into what research is out there and how people are talking about cannabis in the research field. Other than that, I think we're going to say goodbye to you all today, and thank you again for coming. Thank you to our speakers for taking the time out of their very, very busy weeks to talk about what they're doing and how it connects to public health. And I hope everyone who is with us today is inspired to see public health as a way to approach cannabis and see their work as public health that they do every day. Thank you all. Have a wonderful day.
Thank you,
Thank
everybody.
you.